It's on the clock is a little over 9, so I think we should get started. So it's my great pleasure to introduce Dr. Eileen Dolan. She's the Deputy Director at the University of Chicago Comprehensive Cancer Center, and she's a full professor who has been a world-leading expert in pharmacogenomic research. Sort of a personal touch, she actually was my postdoc fellowship mentor back in 2000. Well, we look back, it was time just fly. It's been 20 years, but I still remember all that fun time, very productive. She was the reason at the time I had a choice of going to industry or staying in academia. And she's the reason. After chatting with her, I feel like, well, this is something so cool and fun. And that really is one of the turning point for me to stay in academia. So always grateful to her. As if you have seen her CV, it's super impressive. She has over 200 publications, many of which are in leading journals. And just last year, she was the recipient of MD Anderson Margaret Kripke Legend Award for promoting and supporting cancer research in women in their career track. So she has always been an advocate for, cancer research in general, and also very supportive for her trainees and training the next generation scientists devoted to advanced cancer research. So we're in the tree for Dr. Dolan's speech today. Thank you.
Well, thank you so much. Thank you for inviting me here despite -8 this morning. It's still wonderful to be here. And, and looking back at several decades of research, I have to say with all honesty that the most enjoyable time in my research careers was when Steph Wang was in my laboratory. It was so productive and so exciting and so fun. Part of it was we complemented each other really well in terms of our expertise, and both kind of had the same work ethic. So today I'm going to talk about genetic and modifiable risk factors for chemotherapeutic-induced neurotoxicities. So, we all understand that survival outcomes for all cancer types continues to improve, which is great. However, there's over 28 million cancer survivors worldwide, and we expect even in the United States alone by 2040 for there to be 26.1 million cancer survivors. So it gives us a real heightened awareness for their quality of life, the toxicities that they experience throughout their entire remaining life, and how we've affected their life with chemotherapy and radiation. So I'm going to talk about some of the adverse effects of cancer treatment. Obviously, there's very serious toxicities due to including pulmonary toxicity, cardiac toxicity, hepatic toxicities, but there's also a series of neurotoxicities. Peripheral neuropathy is very interesting to me because of the fact that 30% of all patients that get chemotherapy have some form of peripheral neuropathy, and it can really affect their quality of life. Many of them can't feel their hands and their feet. And so in the severe cases, it really can affect exercise. It can ultimately result in congestive heart failure and diabetes and other chronic conditions. I've also been very interested in ototoxicity. Cisplatin causes ototoxicity, both hearing loss and tinnitus, but we've also delved much deeper, looking at speech recognition threshold that I'll talk a little bit more about, speech and noise, and other forms of understanding language and conversation for individuals, especially young adults or children who have been treated with radiation or cisplatin and then have their whole life ahead of them with this devastating toxicity. And just as a sidebar, my daughter, not knowing that I'm interested in this, actually ended up getting her doctorate in audiology. So she is an audiologist out in Chicago. And we're also interested in dizziness and vertigo as well. So my work is really not just looking at clinical and behavioral and modifiable risk factors, but also the genetic factors that play into these toxicities. So I'll talk about neurotoxicities associated with chemotherapy, the characteristics of our specific cohort, the different toxicities that we've been measuring, and the impact on their quality of life, and then talk about the risk factors, including platinum levels in the serum, age, dose, modifiable factors, pharmacogenomics that are related, and how genetic ancestry plays into that. And then I'll touch at the end about our childhood cancer survivor study. So the Platinum study, which was really headed by Dr. Lois Travis at the Indiana University, is one of probably the best characterized and well phenotyped cohort which receives cisplatin. And so this particular cohort is testicular cancer survivors. We have over 1,800 now, and we have lifelong follow-up. So we have a couple of different times in which we've measured, taken blood and done genetics, but also have them fill out a questionnaire with some of the issues that they're experiencing. So what's beautiful about this cohort of patients is that around the world, they get either bleomycin etoposide platinum 3 cycles or etoposide platinum 4 cycles. So it's a very uniform treatment. They have about a 96% survival, and they're young adult males, predominantly of European descent. So this pretty much affects Europeans. We do have a number of patients that are of African descent and individuals of Asian descent, which I'll talk about during, to tell you a little bit about how geographic ancestry affects toxicities. But most of them are about, this average age is about 29 years old. So they're in 20 and 30-year-olds. And then we evaluate them at both 4 years after and about 8 to 10 years after. So the rationale for our studies is that platinum compounds are one of the most widely used group of cytotoxic drugs worldwide. So what we're learning about the toxicities can really apply to ovarian cancer patients, head and neck cancer patients, or other patients that get cisplatin. And then there's no FDA-approved agents for the prevention or effective treatment of these neurotoxicities. And so this just gives you kind of an outline of what we've been measuring from these patients. So these patients are brought in after they have been treated. So this might be 4 or 5 years after their treatment. We have them fill out a 29-page questionnaire about their health conditions, their lifestyle factors, drinking, smoking, and so forth. But we also take blood specimens in order for us to do genomic tests, as well as cholesterol panel, and other measures, including the platinum level in the serum. And then we do audiometric testing, as well as confirm in their medical record the dose of the drug, as well as the therapy and the diagnosis. So most studies that have done hearing loss in patients have either done self-report or some other form of hearing loss, whereas we're looking at audiometry all the way to 12 kilohertz. So the way this works is that you get a sound at several different kilohertz, and we measure the degree to which they can, they are able to hear the sound, how far up we have to sort of elevate the sound for them to hear it. So this just shows you, many of you have probably had this test when you were young and you didn't have it up to 12 kilohertz. You have to have special equipment for that. But the reason we did that is because it's mostly in the high frequency range. And there's not a full understanding, if you have just high frequency loss, how that affects your ability to hear. It's likely to affect your ability to hear, let's say, in a noisy environment. It affects certain sounds that you normally would be able to hear. So, but we decided to go all the way up to 12 kilohertz because of our knowledge that this affects high frequency in the high frequency range. And we had about 20% of our patients had normal hearing after their cisplatin, but 80% had some form of hearing loss, with 18% having either severe or profound hearing loss. Now you can imagine a patient that's at the end who's dealing with profound hearing loss. You cannot give them a hearing aid to amplify sound because there's no sound to amplify. These patients would have to have a cochlear implant. So it's really serious when you're talking about a 20 or 30-year-old who has been able to hear up to this point, and you're curing them of their cancer, but now they have 50, 60 years ahead of them with an inability to hear. So the other measure that we took was speech recognition threshold. And this is deficits in speech understanding. It constitutes one of the most severe consequences of hearing loss. So it's speech and conversation. And it's measured by providing them with these spondaic words. So they're 2-syllable words, and they have to repeat them. Now you're giving them the word at a level they can hear. So for some patients, you obviously have to turn that up to a certain level. And then they have to provide you with the word back. And this very much correlates with sound in like the 2 to 4 kilohertz range, because that's when we converse. That's the kilohertz, around 0.5 to 4 kilohertz. So those correlate really well, but that's a really important measure, because it's not like sort of we're just saying, okay, they've had hearing loss in the high frequency range. Now we're saying they really cannot have a conversation if they can't repeat these words. So cisplatin-induced hearing loss is usually bilateral. It's both ears. It's irreversible. It's sensory neural hearing loss. And as I mentioned, about 80% of our patients have some form of it. Some with a milder form, but 18% was very serious. And we see about 500,000 cases in the United States annually, and the lifetime cost of hearing loss in a young adult is about $500,000. And this is primarily due to loss of productivity. So these patients not only have issues with communication, but job productivity. They have health-related quality of life issues. Socialization is a problem. Many of them will suffer from depression. They have fatigue. It's actually tiring to not be able to hear and to try to be in conversation. It's a sort of heavy cognitive load. And then it can lead to cognitive decline and dementia. So there's very clear association now in the literature that hearing loss is associated with cognitive decline. So for tinnitus, the phenotype, you can't measure that quantitatively, so you have to ask the patient. And so within this questionnaire, we ask it twice so that we ensure that we're getting consistent results. We ask, do you have ringing or buzzing in the ear? And then we ask, have you suffered from in the last 3 weeks from ringing in your ears? And if they consistently say no or not at all, those are our controls. And if they consistently say yes, and quite a bit very much, those are our cases. So we're taking the more severe cases, we're throwing out or not considering those who have a little. Tinnitus, again, if this is permanent, it's this external stimuli. You feel like you're listening to buzzing or hissing or some kind of sound which is not present. It's all internal. There are a few patients where a physician can actually hear the ringing, which is very unusual, but that's not most of the cases. And 13 to 22% develop severe tinnitus. It can worsen with time, and there's no medical treatment for it. It interferes with sleeping, concentration, and promotes anxiety and depression, reduce productivity, and there's a 13-fold risk of cognitive decline or dysfunction for these individuals with tinnitus. And in extreme cases, there's been evidence for suicide due to severe tinnitus. And then the other toxicity that we're measuring and learning about is this peripheral neuropathy. And this is characterized by functional disturbances of sensory nerves. So it's like a sensations of tingling or numbness or pressure or cold or warmth in the hands and the feet. It kind of goes up the hands, it goes up the feet into the legs. And it's caused by mechanistically very different chemotherapeutic agents. And even some of the newer targeted agents cause neuropathy. And it may be because the peripheral nerves are kind of being bathed in chemotherapy, and this damage that occurs, whether it's cisplatin or these vincristine, the taxanes, the alkaloids. So a number of different mechanistically different agents. And this is again measured in our case through a questionnaire. And so we're asking about tingling in the hands and feet. We're asking about numbness. We're asking about shooting or burning pain. And then we take these 8 items and we conglomerate them into a single value. And then we have a group that are, know a little, quite a bit, very much based on their responses. And these, the complications can be detrimental because in some cases, you have to dose modify patients. And this would occur more frequently. And for example, if a patient got paclitaxel and they could give them a lower dose or a different drug, but with testicular cancer, and you're dealing with 95% cure rate, because of cisplatin, there's no altering that dose. They will not dose reduce those patients. So they're going to live with whatever neuropathy they get after this. So it's a profound impact on their quality of life. There's no agents that are established to treat this, prevent it. Duloxetine is used if you have neuropathic pain. But in our testicular cancer survivors, we've actually related this to worse global mental health, as well as significantly increased 2 to 3-fold of subsequent mortality. And the average age is about 48 years old. So these patients may be dying because they're on opioids to deal with the pain of neuropathy, or the fact that there's lower physical activity. There's generally weight gain we're seeing. There's also higher alcohol consumption. And then we have a subpopulation that we've measured that have what we call multiple severe toxicity. So these are greater than 1 toxicity. And in this group, we had 196 controls in 104 cases of either 2 or 3 severe toxicities. And 38 of our patients had really severe toxicities of all 3. And so I'm going to talk about some of these risk factors. One of the things we were thinking might be contributing is the serum platinum levels. They stay in the body a long time. And there was evidence that you have up to 1,000 times the normal levels for up to 20 years. And this was in a study showing that 10% of the platinum was still reactive, and that the urinary levels were 100 to 1,000 times. But most of the studies to date had been on smaller cohorts of patients, and they had only taken a single time, didn't take into account time or dose. One of the studies had 169 patients and reported serum platinum was related to neuropathy, Raynaud phenomena, and tinnitus. And so we had obviously 10 times as many patients, so we decided to look at this much more closely. And we worked with Mark Ratain on this, who's world-renowned pharmacokineticist. And we identified that the platinum remains in the circulation at exceptionally high levels for up to 3 decades. And so we constructed a bi-exponential pharmacokinetic model, and for taking into account time since treatment and taking into account cumulative dose. And we evaluated the platinum and determined its relationship to the severity of a number of toxicities. Now, each dot on this plot represents a single patient. They were taken at a single time, so it's a population pharmacokinetic plot. And what we identified was that these levels of platinum were related to multiple severe toxicities. So if you had high levels of serum platinum versus low levels, you were much more likely to have the multiple severe toxicities. There's also a very strong inverse relationship with renal function, and there was a relationship with tinnitus as well as Raynaud phenomenon. So we wanted to look at a number of other factors. Does age play into it? Does these clinical risk factors like the dose, the hypertension, hypercholesterolemia, and what are the modifiable risk factors that may be playing into these? And so I know this is not a good slide because it's too detailed, but it just gives you an idea of us looking at all of these different variables and looking at the odds ratio and which ones were associated with hearing loss, tinnitus, and neuropathy, of which these toxicities tend to be related. People who have hearing loss will more likely have tinnitus and vice versa. But I'll show this in a better way. And so this is shown where I'm just giving a check mark. So age, across the board, the older you are, if you have testicular cancer and you're getting cisplatin, you're much more likely to have hearing loss, speech recognition threshold, tinnitus, peripheral sensory neuropathy, and multiple severe toxicity. The dose, interestingly, was related to hearing loss, tinnitus, and multiple severe toxicity, but not related to sensory neuropathy nor speech recognition. And you can see on the bottom, there's a graphic showing this cumulative cisplatin dose. So there's almost no toxicity. I shouldn't say no, there's some degree of increased toxicity or increased number of frequency of patients that have toxicity. But once you reach 400 mg per meter squared, and you go over that value, and there's some patients who are maybe more at risk, so they give them more cisplatin, they're really at 2.6-fold risk of getting tinnitus. Smoking was related to everything except for hearing loss. Alcohol consumption was related to peripheral sensory neuropathy. And as I mentioned, these patients are less likely to exercise due to their neuropathy and more likely to consume alcohol. The definition of sort of high or by NIH of alcohol consumption being severe is 2 or more drinks a day. So I don't know. I know on a college campus, it's probably happening here, but maybe it's not considered high alcohol consumption. But anyway, hypertension associated with all except for the speech recognition, and BMI it was associated with several of the toxicities, but only increase in BMI was associated with peripheral sensory neuropathy. So increase from the time of diagnosis to the time of clinical evaluation. And then hypercholesterolemia was very much associated with tinnitus. And this also, as I mentioned, you know, it causes, there's a relationship with functional impairment as well. So this is a measure of emotional and social effects. And so if you have very much hearing loss, you're much more likely to have emotional and social effects of that. As well as for tinnitus, we do a measure of it's a questionnaire for concentration, emotion, hearing, and sleep. And the more tinnitus you have, the higher the values are for these, which means the worse functional limitations you have. And we also measured, we asked them about their health. You know, what would you say is your overall health? Is it fair? Is it poor? And you can see individuals, as you would expect with multiple severe toxicity, are much, much more likely to say it's poor, are very poor than, or fair or poor than it is good or very good. So we also did genome-wide association studies on all of our phenotypes. This just shows you the results of those. We first looked at, well, it wasn't first, but we looked at peripheral neuropathy, and we did both a GWAS looking for SNPs, and no SNPs were significant or reaching genome-wide significance. So then we did a gene-based analysis, and we identified RPRD1B as one of the genes really important in peripheral neuropathy. And that was published previously. And then we identified FAM27 as being associated with multiple severe toxicities. And this is a calcium binding and bone mineralization. It has the influence on the ability of bone to absorb and secrete platinum into the circulation, which is interesting because I just showed you this plot in which individuals that had higher degrees of serum platinum were more likely to have multiple severe toxicities. And then we also found WFS1. This was a genome-wide significant signal, and that was, this is a transmembrane protein. It's involved in ER stress and calcium, and that was associated with hearing loss in our patients. Otis was found to be associated with tinnitus in our patients. And then we looked at speech recognition threshold, and we did not find genome-wide significant signals, but we did find 29 suggestive variants that were associated. And lastly, and this was very interesting, we used serum platinum as the phenotype. So we're now asking, what are the genetic variants that make one more likely to have high levels of serum platinum? And we found MYH14 to be, this is a myosin heavy chain 14, and this was genome-wide significant associated with individuals that have high levels of serum platinum. And this particular gene and this finding was important because, as I said, it encodes for this heavy chain of muscle, non-muscle myosin 2, but it's essential for kidney development and function. So in mice, it's expressed in most segments of the renal tubule and implicated in the regulation of epithelial transport. And cisplatin, we know, is excreted mainly through renal clearance. And we know that there's pathogenic variants within this gene, MYH14, that are associated with hearing loss. And the SNP in the first intron of WFS1, which was associated with hearing loss, was genome-wide significant, as you can see here. It was also an EQTL, or a SNP that was also associated with the expression of WFS1. So individuals that carried a particular allele or the CC genotype had lower levels of WFS1 than individuals that carried the non-risk allele. And this just shows you a plot. So individuals that have a CC allele of WFS1 in this particular genotype, if they are getting 4 cycles as opposed to 3 cycles of BEP, they are much more likely to have a higher degree of hearing loss. And so this is important because physicians can treat patients with either BEP or EP. One is 3 cycles, one is 4 cycles. And the decision is usually based on the fact that, so bleomycin, some physicians don't like to use bleomycin because it can cause lung toxicity. And so they avoid that. And so they go to EP, which is 4 cycles, but they're both equally effective. And you can see that you're going to have, if you have patients that have this CC allele, they're going to be much more likely to have hearing loss if you're giving them the EP regimen. And we wanted to ask the question, you know, there are also Mendelian deafness genes, and is there an enrichment of those particular SNPs within our GWAS? And we did identify that there was elevated SNPs within 84 Mendelian deafness genes. 33 genes had at least one SNP with a p-value of less than 0.01. So there seems to be some overlap of genetic architecture between Mendelian forms of hearing loss as well as cisplatin-induced. WFS1 encodes for Wolfram gene, and we know that Wolfram syndrome, which is a rare autosomal recessive progressive neurodegenerative disorder, is associated with both neuropathy as well as hearing loss. There's more than 200 mutations known that leads to the production of Wolfram protein that's reduced. Now, remember, if you have, in our studies, we showed that lower levels of WFS1 were associated with a much higher degree of hearing loss. And so what we think is happening is that WFS1 is a protective protein. And when you lower the levels, the calcium levels within the cells are not regulated and the ER does not function properly. So you have the endoplasmic reticulum that doesn't have enough functional protein, and the cell is going to trigger its own apoptosis. You have cisplatin, which is perturbing the system, also causes apoptosis. So in the presence of low levels of WFS1, it's likely causing much more damage, and that's the reason why these patients are having a higher degree of hearing loss. We also wanted to ask whether there's differences in the prevalence of cisplatin-induced toxicities in different ancestral populations. So, you know, our individuals of African descent or Asian descent have higher degrees of either hearing loss, tinnitus, or neuropathy. And as I mentioned, we didn't have huge numbers of African Americans because this primarily hits Europeans, but we did have enough to do these studies. And one of the reasons for this study is it had never been done before with cisplatin, but there was a lot of evidence out there for that both the incidence and severity of peripheral neuropathy to be much greater in African Americans after taxanes treated for breast cancer. So one study had shown that the proportion of African Americans compared to European Americans receiving paclitaxel had much CIPN-related dose reductions. There were studies that showed breast cancer patients that had paclitaxel had much greater degrees of grade 3 to 4 paclitaxel-induced peripheral neuropathy, and so on and so forth. So all of these studies are separate studies showing either the incidence or the severity was greater in African Americans than it was in European Americans. But these studies were not done looking at genetic ancestry. They were done with self-report, which you know correlates well, but it's very clear that there's a difference. We had some evidence that we had looked at cumulative burden of morbidity. So now we're looking at all of these different toxicities that patients experience, and we're putting them together into giving them values of each one, giving it a value. And we found that obesity was the highest, most prevalent adverse health outcome after getting this treatment for testicular cancer at 71%, neuropathy at 56%, tinnitus at close to 40%, and hearing damage at 39%. And so we took these and we asked the question, are Africans more likely to have high cumulative burden of morbidity? And it is true, it didn't turn out to be significant, but if you evaluate the percent of patients in the high, very high severe group versus other groups, whites 19% are in that group, African Americans 37%, and Asians 8.5%. So there's some hint that they're getting more severe toxicities. So what we did was we took all of our patients, we put it up against the 1,000 Genome Project in order to do multi-dimensional scaling analysis and assign geographic ancestry to different groups. So you can see we have a European group in red here, the Asian group, or maybe that's orange, and then this is red. We have a green of Africans, and then we had a subgroup that were more African descent. So we looked at that group separately as well. And what we identified was that if you're in the group that's more African, you're much more likely to have neuropathy than Asian or the group of Europeans. Sorry. It's also true that you're more likely to have vertigo. So these two toxicities were more frequent in the African population than the other two populations. We did not see the case for hearing loss or for tinnitus. So there were no significant differences for those two toxicities. Well, one could argue maybe it's because the Africans are more likely to have diabetes or some other chronic health condition. So we did look at that. But I did want to also report that individuals of African descent are also more likely to report their overall health as being fair or poor. And in doing an analysis of individuals that are reporting that, they actually have a higher mortality, that particular group of patients. So they're not just complaining about not feeling good, they're actually not feeling good. So we evaluated all of the different, a number of different, like cholesterol medication, blood pressure medication, are those other population differences. And the only difference that we observed was blood pressure medication was more frequently prescribed in the African population than that of Asian or European. But no difference is in diabetes, in smoking, and drinking as well. So we thought that this difference in peripheral neuropathy and vertigo may have something to do with allele frequency differences between the populations. So part 2 of our studies were to take all of the SNPs with a certain allele frequency difference in the populations and evaluate those against our toxicity, but also to subgroup the group of SNPs that might be functional, so EQTLs or SQTLs. And we knew from the literature that vascular toxicity is similar to toxicity associated with environmental heavy metals. And we know that pharmacogenomic alleles vary across populations. So there's a lot of evidence out there that pharmacogenomic markers for drug response vary in frequency in different ancestral populations. And so that this was really the impetus for us to hypothesize that there's allele differences explaining these differences in the toxicity between the populations. And so this just shows us starting with 3 million SNPs and going down by saying it had to have an FST of greater than 20.25, and then also having another set of criteria, which included they had to be functional, and then we ended up evaluating 19,000, a little over 19,000 SNPs for their relationship to the toxicity. We also did a separate study by just evaluating cisplatin-associated SNPs from the literature. So we did a very thorough literature search, and we started with, I think it's 38,000 there, and we got about 118 SNPs from that group, which we combined with our 19,000. And so we did identify an EQTL for RNF 24, which was associated with peripheral sensory neuropathy. And you can see that Africans are much more likely, they have 90% if you're in that African group versus 69% for the whole line across for the African axis, and then 61% in Asian and 7% in European. And that particular SNP was identified, there were 6 different SNPs that were identified that were associated with neuropathy that were also associated with that were separately, not in LD with one another, but associated with this particular gene, RNF24, the expression of this gene. So independently, a set of SNPs, all associated with the associated with the expression of this gene and toxicity. So this is, it regulates intracellular trafficking of a transient receptor potential cation. We know that this particular cation TRPC is also associated with intracellular calcium levels. And there's a lot of evidence that cisplatin is more toxic if the calcium levels are off. There was a study to show that calcium levels are really important in cisplatin-induced injury, and a variant in ACYP2 was involved in calcium homeostasis, is essential with increased cisplatin-induced ototoxicity in children. And that's been shown in probably 3 or 4 different studies. So now we are doing machine learning. We're taking our clinical variables, we're taking lifestyle variables, and we're taking genetic variables, and we're putting them together and building models in order to predict patients that are at the greatest risk for these toxicities that I've talked about today. So lastly, I'm just going to touch on, in the last couple of minutes, our childhood cancer survivor study. And this is a study in which we've looked at radiation-induced hearing loss and tinnitus. So in contrast to the platinum study, in which we're very, very carefully measuring all of these toxicities in the patients, the childhood cancer survivor study is one in which they're going to survivors of cancer. So they had cancer as children, and they're asking them when they're like in their 30s and 40s, do you have hearing loss? Do you have tinnitus? So it isn't these audiometric measures like we were doing, but it does provide a lot of data, and it's longitudinal data. And it was one of the best data sets to look at the effects of radiation. Now, this was about 1,991 cancer survivors, and they were followed up with questionnaires, as I mentioned. And tinnitus status was, again, from this questionnaire, similar to what we had done. There were 146 cases that said they had tinnitus, and it was still present, and 1845 controls. And so they had genotype data we were able to get through dbGaP. Now, unlike cisplatin, which causes bilateral hearing loss, radiation, because it, you could be radiating more on one side depending on where the brain tumor is or where the tumor is in a child, it can cause unilateral hearing loss. And it typically occurs after 30 grades of cranial radiation. The incidence is variable. It can be up to 85% of patients, depending on what you're measuring in terms of the kilohertz for the hearing loss, but also the amount of radiation. And what we identified is when you go above 45 grays of radiation, you really have a very high degree of individuals that have both hearing loss as well as tinnitus. And the tinnitus looks a lot like what we saw with cisplatin. You get sort of this flat line of some degree of sort of incidence of tinnitus, but then as soon as you go above a certain, for cisplatin, it was 400 mg per meter squared, and in this case, I think that's 45 grays, you see this huge increase in the proportion of patients with tinnitus. Interestingly, white patients in the childhood cancer survivor have a much higher incidence of radiation-induced tinnitus than the Black patients and others. Males, just like for age-related hearing loss, are more likely than females to report radiation-induced ototoxicity. And this was adjusted for the cranial radiation dose and the age at the last observation. For Males, about 9% of males versus 5% of females get tinnitus. Hearing loss, 14% males versus 10% of females. There is some thought and some literature out there that says estrogen protects against hearing loss. So that might be what's occurring, but keep in mind that these were children that received the radiation, and now they're adults. And we did a genome-wide association of radiation-induced hearing loss in this childhood cancer survivor study. We did not find genome-wide significant signals, but we found some that were very suggestive and close to genome-wide significant. And we decided to put that in a second study, the St. Jude Life cohort study. And we found that 2 of these SNPs, the ones in ATXN1, were replicated in the St. Jude Life cohort. We then looked at UK Biobank, which is a huge biobank of hundreds of thousands of individuals, and we looked at whether or not these SNPs were also associated with hearing difficulty in patients. So they have not, these patients, I'm calling them patients. The UK Biobank, they're not patients, they're just individuals. They did not get cisplatin or radiation. But individuals that said they had hearing difficulty or problems with background noise and hearing in that environment also had this particular SNP, and it was significant. We also looked at radiation-induced tinnitus. Now, we here had a beautiful signal that was genome-wide significant. We were so convinced that we were going to be able to replicate that, but we did not replicate it in the St. Jude Life cohort. And there still might be some value in following up with this. So the clinical implications are hearing loss and tinnitus are permanent adverse effects of cisplatin and radiation. Cisplatin-induced hearing loss and tinnitus impact cognitive dysfunction and fatigue and depression. You can imagine, in the world today, as we're getting more and more individuals with dementia and cognitive decline, it's a huge cost to the healthcare system. And so treating cisplatin-induced hearing loss or even hearing loss de novo would be very important. The genetic ancestry was associated with neuropathy as well as vertigo in African Americans being much more susceptible. And we identified a number of signals. The only 2 I'll just remind you of is WFS1 and OTUS for hearing loss and tinnitus respectively, and this ATXN1, which was replicated in 2 other groups associated with radiation-induced hearing loss. I'd like to stop there and acknowledge for the testicular cancer study, our PI and epidemiologist, Lois Travis at Indiana University. And then the pharmacogenomics group is my group, which includes Cindy Zhang and Matt Trendowski, Mohammed Shabasi, and Sweta. And then Nancy Cox has helped us with statistical genetics, as well as a group for hearing scientists and our clinicians. And then the childhood cancer survivor group, which includes Greg Armstrong and Smita Bhatia as the main 2 individuals that worked with us on that. So I'd like to stop there and thank you for your attention. I'll be happy to take questions.
Great. I have microphones for anyone who has a question.
Thanks for the great talk, Eileen. So I guess I'm wondering whether you think it's feasible to identify patients who might be metabolizing these chemotherapies differently and do dose de-escalation so that you could reduce the chance that they'd have these toxicities. I guess I wasn't sure from what you said whether you think that's a realistic option.
It's realistic in some scenarios. So it's realistic if you have an alternative, equally effective drug. But cisplatin is curative in testicular cancer, and carboplatin is not. So they're not going to switch over on that, a young adult getting cisplatin. So I feel as though, in understanding the genetics and trying to do sort of predictive measures for these patients, in this case, maybe we'll be able to tell a physician to use the 3 cycles versus 4 cycles. They're, depending on their genetic profile and other factors that play into that. But the other thing is, when we understand the genes that are involved, that's when we can begin to create drugs that may be effective to prevent or treat it. And I think that's where we have to go.
So one follow-up question related to platinum toxicity then. about what you just said. You know, I imagine identification of some of these SNPs may suggest a drug target
Mhm.
or a process such as calcium levels. But for platinum toxicity, how long do you think you'd have to protect the cells? Because you mentioned it sticks around a long time.
Mhm.
So when is the critical period of toxicity occurring?
It's happening early on in the first 6 months during treat. Yeah, it's happening early on and then it's permanent. So, it sticks around and you could try to get rid of it, right? After you've cured a patient. But the problem is, the real challenge is that these occur either during or within the 6 months after treatment. And then you don't want to, it's hard to kind of alter the dose or dose modify in that case.
That was a really informative talk, and I was impressed how long platinum hangs around. I actually didn't realize that it can stay for decades. But it then raises the question about outcomes and drug levels. So you clearly showed drug levels are associated with worse toxicities,
Mhm.
but are they associated with better outcomes? And I'm asking because
Yeah,
you're looking mostly in survivors, right? So you don't have
exactly.
the
We don't have.
pre-treatment cohort.
Exactly. So that's, I think, probably one of the limitations of this study, the biggest limitations. We don't have pre-treatment levels. We're looking at these patients post-treatment and trying to make associations from that. And yeah, so you're absolutely, you're right in what you're saying. Yeah.
Yeah, I hate to, as an oncologist, there's a variety of it.
Right.
I know you're aware of this, various chemoprotective agents, especially for platinum. When I was a fellow, we were evaluating one of them, but they always made the outcomes worse. So
Yeah.
almost none of the chemoprotective agents have ever graduated into clinical practice because maybe those high drug levels are why those people are survivors.
Right. And in this case, when you have 95% cure rate, we're looking obviously at just the survivors, right? When you have a 95% cure rate, you're absolutely right. This is it's hard to figure out if you had pre-measures and you knew who survived and who didn't, but it's still, you need large numbers because you're having so many of your patients survive.
So that was really fascinating, and it points to the law of unintended consequences, right? For every good thing we do, there's consequences. I was wondering if there's a way to actually quantify or evaluate the phenotypes as opposed to just risk genotypes, and to understand if what's happening is an acceleration of aging decline. And so it might be that in these patients, chemo is inducing an aging phenotype.
Right.
And are there things that we can learn from these guys that we might also apply to, assuming that we learned something useful, right? Can we apply it to people that have never been exposed to chemotherapy but just happen to be in the old cohort and have some of the same deficits?
You're absolutely right. We're accelerating aging. That's what we're doing when we're perturbing the system with cisplatin. And we have patients that, particularly at the 400 mg per meter squared at the higher dose of cisplatin, where their hearing loss is bad right after, but it's actually worse with time. You see what I mean? So we know there's age-related hearing loss, but now we're accelerating that dramatically by providing a phototoxic agent on top of that.
Are there ways to actually look at molecular phenotypes, transcriptional programs?
Yeah. Yeah.
Even if it was systemically rather than, there might be some really interesting.
Like look at metabolism or the metabolic profile or something like that over time. Yeah, we definitely, and try to identify also maybe biomarkers.
Yeah. If you have a few minutes when we're done, I can tell you some of this.
Yeah, we do have blood to do this sort of work. We just haven't done it yet.
Please raise your hand if you have any questions. In the meantime, I do have one online. How has the community received this information? Would people think that the cure is worse than the disease?
Well, that's a good question. I mean, certainly for these, 48-year-old who is now, has on opioids, then I don't know, the toxicities are devastating for some patients, not all of them. And we cannot predict today which patients they're going to be. So I think there's great value in curing the patient, but we need to find ways to prevent these.
Thanks for great talk. I had a question about the GWAS for ototoxicity. Your study had a very strong hit that was genome-wide significant, and it was different than the results from the pediatric cancer GWAS that have
Right.
looked at platinum-related hearing loss. So I was wondering what your thoughts were on whether there are age-related differences or dosing.
Yeah, I really do think there's age-related differences because the ACYP2, which was first brought out by St. Jude's, June Yang's group, that's been replicated in probably 3 or 4 studies. So that I'm very confident in that. Our analysis, we did a geometric mean, so we're looking at high frequency hearing loss, and that was replicated by a Canadian study, not when they just did an audiometry test or an audiologist said they have hearing loss or not, but when they took the geometric mean. So it could be that WFS1 is far more important in the high frequency range, and maybe when they're doing the pediatric study, it's more in the speech recognition range. So that could be one reason. It could be the age difference of, a young child who's still developing. But that is correct. There's not overlap between the young adults and the children in terms of findings.
Thanks for a very interesting presentation. When you're identifying these SNPs in your GWAS studies and associating them as EQTLs, how are you picking your RNA-seq data set for deriving those associations? What tissue type are you selecting?
good
Is this
question.
consistent across all tissues, or are you trying
No, we
pick up
try
on
to
one
stick
specific-
just with the nerve tissue to look at that, to keep it, because the minute you start doing all these different tissues, there are multiple corrections you got to take into account. So primarily we're looking at the nerve tissue for hearing loss and tinnitus and neuropathy. You can also look at cross tissue, but generally we've stuck with the nerve.
Any?
Great talk, Eileen. My question was regarding, you showed that there was similar architecture for hearing loss with chemotherapy-induced, platinum-induced hearing loss and other types of hearing loss.
Mendelian,
Yeah,
right.
Mendelian. And also the last study where it was across in the UK Biobank as well with just
Right,
hearing loss.
exactly, on that particular SNP.
Yeah,
Right,
yeah.
right.
I was wondering for the peripheral neuropathy, did you find similar architecture between things?
Oh, that's a
there?
good question. I don't know of any GWAS studies on neuropathy.
Okay, I didn't know if there were diabetes.
But there should
studies
be
or-
diabetes. We could look at diabetes. That's a really good question. But we also have recently done 2 studies, one with tinnitus, one with hearing loss, looking at genetic architecture for age-related hearing loss and cisplatin-induced and radiation-induced. And we've also looked at the same with tinnitus, and we found limited overlap. So age-related is likely a distinct set of genetic variables than the cisplatin or radiation-induced. There was like one SNP that overlapped between radiation-induced and the tinnitus and the UK Biobank. So it's limited in terms of hearing loss that you get with age versus cisplatin.
Any additional questions? No? All right, let's give one more round of applause for a great talk. Thank you.
Thank you.